So we did a pooled analysis of neoadjuvant trials in stage 3 melanoma, resectable stage 3 melanoma. Since the SWOG S1801 trial that has been presented last year, we are pretty confident that neoadjuvant immunotherapy in stage 3 melanoma is the way to go. In the Netherlands Cancer Institute, in collaboration with the Melanoma Institute Australia, we have a lot of experience with trials investigating neoadjuvant Ipilimumab plus Nivolumab in various schemes in the OpACIN-neo trial. And with this pooled analysis, we try to assess which scheme is the best regimen for the neoadjuvant setting. And most importantly, we want to address if we should treat patients with anti-PD-1 monotherapy or with a combination of anti-PD-1 plus anti-CTLA-4. And this difference is very important given the superior efficacy that we already saw of anti-PD-1 monotherapy and the NADINA trial that's now testing anti-PD-1 plus anti-CTLA-4. And the biomarker that we are very interested in is the RNA signature, the interferon-gamma signature, 10-gene RNA signature that we assess in the tumor biopsies at baseline. In our analysis, we combined the data of three trials, the OpACIN-neo trial, the PRADO trial, and the DONAMI trial of patients that had tumor biopsies at baseline. And we saw that patients with anti-PD-1 monotherapy that had a high interferon-gamma signature, meaning that they would likely react to immune checkpoint inhibition, had indeed a very high major pathologic response rate of 80%, and also high event-free survival after 80 months of 100%, so actually perfect event-free survival. This compared to patients with anti-PD-1 plus anti-CTLA-4, this was actually very similar regarding the major pathologic response rate from 74% or 78% for EP 1 milligram per kilogram plus Nivolumab 3 milligrams per kilogram, or Ipilimumab 3 milligrams per kilogram, Nivolumab 1 milligram per kilogram. And for their combination therapy combined, we saw an event-free survival of 89% after 18 months. When we look at patients with interferon low signature, we think they will react much worse to immunotherapy. And we saw for patients with Ipilimumab 1 milligram per kilogram and Nivolumab 3 milligrams per kilogram that they had major pathologic response rates of 41%, so much lower, which was expected. Interestingly, patients with Ipilimumab 3 milligrams per kilogram and Nivolumab 1 milligram per kilogram, so the flip dose with a higher dose of Ipilimumab, had better major pathologic response rate of 64%. So we hypothesized that patients with interferon-gamma low signature need higher doses of Ipilimumab to achieve similar outcomes, or at least better outcomes when they have an interferon-gamma low signature.